Hello, and welcome to the Dementia Capable webinar series provided by the Rosalind Carter Institute for Caregiving in partnership with the Georgia Division on Aging Services. Before getting started, we advise having a pen and paper ready to write down any information to the links and resources as they are provided. Otherwise, you will have to view the webinar again to retrieve it later. You may pause the webinar now if needed. Remember that the link to the SurveyMonkey post-test will be pasted onto the last slide. The post-test will remain open for an indefinite amount of time. Please take it at your earliest convenience, though we encourage immediately following the webinar. A certificate can be provided when entering your email address at the end of the post-test. Today's webinar will be Serving People Living Alone with Dementia, presented by Suzette Benford. Suzette received her bachelor's degree from the College of Charleston and her master's in clinical counseling from the Citadel. She worked as an individual, marriage, and family counselor for several years before entering the field of geriatrics in 1993. She has worked in a variety of settings with older adults: nursing homes, assisted living facilities, rehabilitation facilities, and inpatient geriatric psychiatric units. Suzette has been with the Alzheimer's Association Georgia chapter for 11 years and is the programs director for the Atlanta region. Welcome, Suzette.
Thank you so much, Elizabeth. It's wonderful to be here. I'd like to thank the Rosalind Carter Institute for inviting me to do this webinar today. I know that in my office at the Alzheimer's Association, we're serving more and more people with dementia who live alone, and I suspect that all of you are seeing the same thing. And so I hope this webinar today will be helpful in giving you some background information about people who live alone, what their issues are, and how we can better serve them. So these are our learning objectives for today. We'll talk about the prevalence and the characteristics of people with Alzheimer's and other dementias who live alone. We'll talk about their care needs, safety issues, issues around self-neglect, financial exploitation, and their social support. We'll talk about special considerations for providing services to this population, and we'll talk about resources for them. First of all, I wanted to say just a few words about the terminology and just go over some basic definitions. I still think that there's a lot of confusion about the difference between dementia and Alzheimer's. And a lot of folks think that dementia is something less serious that just sort of gets worse over time and builds into Alzheimer's. But actually, dementia is just the big, broad umbrella term, and that's why I've put that little umbrella icon for you there. It just means a loss of cognitive functioning that's serious enough to interfere with daily life that's caused by some medical condition. So the question is, what is the medical condition that's causing those symptoms? The memory loss and the language decline and the judgment and those kinds of things. And so one of the reasons that it's important to get a diagnosis as early as possible or to go for an evaluation is that there are physical things that can cause the symptoms of dementia that are potentially treatable and reversible. And, you know, one of those is depression. If depression is severe enough, it can cause memory loss, and it can cause people to get misdiagnosed with dementia. Another thing, a lot of you know, in older adults, if they get urinary tract infections, UTIs, it can make them very confused and disoriented and make them really look like they have some kind of dementia. There's also drug interactions and a lot of other things. But on the other side of the umbrella of dementia are the progressive, degenerative, irreversible causes of the symptoms of dementia. And the number one most common of those is Alzheimer's. But we also have Alzheimer's, Lewy body dementia, frontotemporal dementia, vascular dementia, and a whole lot of other ones. Alzheimer's, though, you see different statistics, but we think about 60% at least of this type of dementia is Alzheimer's disease. And so when someone calls me and they say, Suzette, Mom doesn't have Alzheimer's, she just has a little bit of dementia. Well, if I'm looking at that statistically, Mom probably, it's likely that she may have Alzheimer's, but it's probably just in a very early stage, and that's why they're describing it as a little bit of dementia. So again, just wanted to make sure that we talk about dementia as this big umbrella term. I also wanted to say just a few words about the difference between early stage and early onset. And a lot of times I hear people saying early onset when what they really mean is early stage. So early stage is somebody of any age whose impairment is just mild. So you could have an 85-year-old in the early part of the disease. That's an early stage person. And then we have early onset. This refers to someone in any stage of the disease whose symptoms occurred before the age of 65. So if you have a 70-year-old who is now in the middle stage, that's still an early or onset case because his symptoms started maybe when he was 62 or 3. So to differentiate the two terms, we're now starting to call early onset younger onset, just to sort of think about people who have this type of dementia, that they're getting it when they're younger. And then finally, just a word about early versus middle versus late stage. For this particular topic, the people who live alone with dementia, most of the people that we're going to be talking about are in the early stage or possibly the early part of the middle stage because, obviously you have to have at least some abilities and your impairment can't be too severe to still be living by yourself. But what we're talking about really in general is if someone's in early stage, their impairment is mild, in the middle stage their impairment is moderate, and in late stage their impairment is severe. And one of the markers that we informally use to determine when someone is moving from early into middle stage is that generally folks in early stage are able to do their ADLs for themselves, their personal care, dressing and grooming and bathing and like that, or maybe just with some mild cueing. But folks who are moving into the middle stage are really needing heavy cueing, or they're starting to need people to actually give them assistance. So that's one of the markers, but I find that usually it's a pretty reliable marker. I also wanted to just make reference to this graphic that we have here. The difference between a healthy brain and that's a cross section on the left. And on the right, we have a cross-section of the brain of someone with severe Alzheimer's. So I want us to really keep this in mind as a context for this discussion, because what we have with somebody with Alzheimer's is that the brain is actually shrinking. There's brain damage going on, and the brain actually shrinks by about a third in somebody with severe Alzheimer's. And so we need to think about the way that this affects the person. And as the brain is being affected, the damage it progresses in a fairly similar way, particularly in the beginning when the hippocampus is damaged. That's the seat of memory, short-term memory particularly, and generally the damage starts there. But the way it progresses through the brain thereafter is sort of a very individual thing, and so that's why everybody with Alzheimer's is so different. We frequently say if you've met one person with Alzheimer's, you've met one person with Alzheimer's, because it's the damage that's done to the person's brain will in large part, determine what their abilities are versus what their impairments are. And so we have to keep in mind that, because someone's speech is very impaired, for example, they may be functionally fairly intact, that sort of thing. We'll talk more about that later, but I want to keep this, this concept of the brain determining folks' abilities and impairments. We really need to keep that in mind. Okay, so first of all, let's talk about symptoms of Alzheimer's and other dementias. We're looking at changes in short-term memory initially, and then as the disease progresses, long-term memory, of course, also becomes affected. And people's judgment is usually affected, as well as the ability to plan and carry out activities. And so one of the things that we often see with people in this kind of earlier stage is that one of the first abilities that goes is their ability to really manage their finances. It's a very common thing, and it's often the first thing that families might notice, that, bills are not being paid, utilities cut off, or because of the issue of judgment combined with that impairment in financial skills, we see people really falling victim to scams and losing lots of money. And we have cases all the time of people who have really sort of lost their life savings because they're in this stage. They've mismanaged their money or been scammed, and then the families find out too late. We see that a lot. So moving on to some of the other symptoms, we've got problems with visuospatial abilities, and that can be seen in lots of different ways. Issues with gait or with being able to read or write. It's also important when you're looking at driving, because many times people's depth perception is impaired. And so that's why we see a lot of people with dementia getting T-boned, because if you're driving and you're going to make a left turn into oncoming traffic, and if your depth perception is impaired and you're not able to tell how fast that car is coming towards you because of your visuospatial impairment, you're liable to pull in front of someone. And so that's one of the big risk factors for driving. And then we mentioned gait. Gait and mobility are often affected. And then finally, a decline in people's verbal skills, language skills, and we see impairments sometimes in people's expressive communication and their ability to communicate what they want to say, and also sometimes in their receptive communication in understanding what's said to them. And sometimes that's why we see folks, this is kind of a red flag, often withdrawing from conversations, because on the one hand, they're not as able to keep up with the conversation as well as they once did. They're sort of also afraid to say something. They can't find the right words, and they're afraid that what they say might indicate that they're not following the conversation. So those are just some of the symptoms that we might be looking for here. In terms of providing services, this is a huge problem. As many as a third of community-dwelling people with Alzheimer's and other dementias live alone. That's a big chunk. A CDC study showed that of all people in Georgia over the age of 60, about 30% of those people who report memory problems live alone. And shockingly, or maybe not so shockingly, about 54% of the people who said they had memory problems, they hadn't talked to a doctor or healthcare provider about it. So the people with dementia who live alone are obviously part of a large group of older Americans who live alone, and we're looking for ways to identify these folks who live alone, because many times they're not identified as quickly as those who live with others, and they are much less likely to have been diagnosed. And we also need to really look at the safety risks for people who live alone. There's less ongoing monitoring of the person. There's nobody there really to recognize maybe at first the subtle changes that are going on, and they're just not observed as closely. So the categories of people with dementia who live alone, first of all, we've got those who live alone, but they've got somebody who visits or helps them out or checks in on them regularly. And then we have this other group who they just really have nobody. They're living alone and they have no support. This graph is all about caregivers of people with dementia. So the blue there are caregivers of people who live alone, and the red are caregivers of people who um, live with them. And so you can see that among caregivers of the folks who live alone, they're doing much less assistance with kind of basic ADLs, bathing, dressing, and especially incontinence. So there's a huge care gap there. They're providing more help with IADLs, but as you can see in general, the caregivers are providing much less assistance to the people who live alone. Okay, let's talk about some of the special issues and considerations when we're trying to help these folks who live alone. The first thing, obviously, that we need to think about is this living arrangement safe? And is it appropriate for them to continue to live by themselves? So just as practical matters, we should be looking at if they were sick or if they got injured, would they be able to understand how to call for help? Would they be able to pick up the phone and call 911? Are there any health problems that might put the person at risk? For example, are they diabetic? How severe is the diabetes? If their blood sugar really gets out of whack, what are the safety measures that are put in place to help them if that happens? Another thing is the person able to take their medication properly? I have lots of folks say to me, well, Suzette, I go and I fill up the pill minder every week, and when I come back, she's taken them all, so, I think we've got that solution. Well, even if it's empty, it doesn't necessarily mean that the person took the medications. Many times when you go through someone's home after they've left, you find lots of things stashed in very unusual places, and one of the things that we find a lot of is medicine and also money. But we have to really look at what kind of medicines are they taking, and are they able to self-administer. Then is the person able to store and eat food properly and safely? We'll talk about that a little bit more later, but just because you have food in the house doesn't necessarily mean that you're eating it safely. There's a problem of eating expired food or not refrigerating it safely and that sort of thing. Then is the physical space safe? Are they able to navigate it safely? If there's stairs, are they safe on the stairs? If it's very cluttered, are there fall risks? Those kind of things. And then finally, does the person really pose a safety risk, not just to themselves but to other people? If you have someone who's living in an apartment, for example, and they're a smoker, is that a danger that they might cause a fire, or are they leaving the stove on with food on the stove? So those are safety considerations. And these are just the general categories of the safety risks: self-neglect, malnutrition, injury, med errors, the financial exploitation, having care needs that are unmet, falls. Wandering is a big one. And then if the person's still driving, are they safe to drive? And as we talked about, the ability to respond to emergencies. Other things that we need to really think about when we're thinking about, is it safe for the person to consider to see if the person's still safe to live alone? First of all, do they actually have a diagnosis, and what is that diagnosis? How long has it been since they got the diagnosis? What is their level of cognitive impairment, and what is their level of functional impairment? Because someone can have some pretty intact cognitive skills, but functionally be really lacking. We'll talk more about that later. Then are they connected with social services, and are they connected with medical care? Do they have access to medical care? And also, of course, we're looking at when we're looking at resources, what's their income, what's their eligibility for services, and of course the availability of caregivers. Is there anyone who's looking in on them either informally or professionally? So in talking about the functional performance and unmet needs of care, the quality of the performance of their ADLs is often very low. And the complex tasks are the ones that are most severely affected. Just wanted to point out that also on the Rosalind Carter Institute website, there are some other webinars that actually talk about how you can use the DONR to both detect and to also investigate whether or not a person has dementia and how severe it is, how you can use a DONR as a tool. But we're looking here at the most common unmet needs are need for companionship, daytime activities, mobility, self-care, housing, in-home care, and nutrition. Those are red flag areas. So let's talk about some just sort of examples, some little mini case studies. A person with dementia might say, right now I do my own cooking, cleaning, laundry, I do the checkbook, and then my son verifies if it's correct. If I mess it up, my friends and family don't give me a hard time. They understand. One of the things that we need to think about when we have a self-report like this is that people don't always give you accurate histories and self-reports. And so if there is a son here, for example, if it's at all possible, it's really good to have the input of other people. You know, people who don't have anybody, you don't always have that luxury. But if there's somebody available, it might be a good idea to ask them, you know, and say, she's saying she's doing her own cooking and the cleaning, but how's that going? Because, you know, sometimes even with a report like that, it's not really being done well. And then the last quote is from a professional caregiver who says, without my help, I know she wouldn't eat the right food. She'd probably go for something quick and easy like grabbing Fruit Loops instead of oatmeal. And so again, that speaks to the danger of malnutrition, or is the person able to prepare food, and also even if they are they eating healthfully to make sure they get all their nutritional needs met. Here's some little studies on safety. The first one is from a geriatric care manager. The most common reason their agency is contacted is to help a person who lives alone after a fall. And so very often this is the first incident that people have is when they have an injury. It's the first time that people start to maybe recognize that something is wrong, and they look at placing them back in the home. And it's, you know, not only do they need help with their, you know, with their daily activities, and they need help with their functional needs, but they also might then be in a situation where somebody's coming in and they recognize that there are other needs going on as well. Then the last quote is the person with dementia. I did some organizing around the house and got rid of clutter, simplified the wardrobe, put labels on the cupboard. And honestly, you know, our goal here is to keep people at home as long as it is safe and as long as possible. And there are some things that we can do to help them continue to live alone. And these are some of the things: decluttering, putting labels on things, and we'll talk more about that in a minute. Some more safety issues. This is from a daughter. There have been a couple of occasions where she's gotten turned around and flustered. She's able to figure out where she was and got back. The key is not to get too anxious so you can think clearly. She'll sometimes ask for help, and I'll always tell her to call me. This is a person that I would be really concerned about their ability to continue to drive. And very, very often, people, even in early stages. Now, somebody in really early stage may be perfectly safe to drive. But when somebody has already had instances of getting turned around and they're not able to easily use a GPS device, that's somebody that we really might need to take a look at in terms of whether it's safe for them to drive, and we'll talk more about that later. The last quote says, I asked a trusted friend if she'd go out with me regularly and watch how I'm driving. When she says I need to make a change or stop driving altogether, I will. And so this is an excellent tip for folks. If it's possible to have somebody observe the person driving, that's always a really great measure to help determine, you know, when it's time to give up the keys, to have somebody else looking in. So now let's move on to the category of self-neglect. So in a nutshell, it's just the inability to consistently obtain food, clothing, shelter, and medical care, maintain basic physical health, mental health, emotional well-being, and general safety, and or manage financial affairs. So here are some warning signs of self-neglect. Dehydration is a huge one. Just, most people in general don't get the recommended amount of water, but for this population specifically, people with dementia, they just don't, as a rule, get enough to drink. They forget to drink, and they end up dehydrated. And dehydration is it can knock over a domino that leads to a lot of problems. And so it's a major concern that we don't sometimes think enough about. But that it's a big sign that there may be some issues of self-neglect. And then malnutrition, we've talked about before. Another one is untreated medical conditions. If the person has, let's just say again, if they're diabetic and they have diabetic wounds that aren't being cared for, there are a lot of different things, but the untreated medical conditions are often present. If they have poor personal hygiene, of course, that's a big one when we're looking for self-neglect. Unsafe or sanitary living conditions, inappropriate or inadequate clothing. We see that lots in people with dementia. They dress inappropriately for the season. We had a case where there was someone who did a home visit for someone whose the electricity had been turned off, and it was stiflingly hot in the house, but the person still had on sweaters, and so they just can't sometimes determine what the appropriate clothes are. And then finally, the inadequate housing or homelessness. Here's a quote: "Meals on Wheels is a fantastic program, but it doesn't work so well when the person won't open the door, open the food, eat the food, or store it." We've gone into houses where the food is sat on the counter because they weren't hungry or didn't recognize that they were hungry, and now it's 2 days later and it's inedible, but they might be consuming it anyway. So another example of just because a service is in place doesn't necessarily mean that it's meeting the need. Okay, this is a case that we dealt with. A woman called to report that her 65-year-old neighbor, living alone, had bruises, and they had taken the woman to the doctor before because she was all banged up and had cuts. The neighbor was able to contact a sister in another state who was the only known relative, but that person had MS herself and just wasn't able to help at all. The police had been to the woman's home 3 times in the last few days, as she kept calling them to report that a family had moved into her house and wouldn't leave, and that her car had been stolen when actually she had totaled it in a crash months before. She had gotten lost and wound up in South Georgia. And the police really didn't know what to do. And so we often get calls like this from neighbors, neighbors of those folks who, really don't have anybody else checking up or checking in on them. And in this case, it almost sounds like to me that she might have some delirium going on, some sort of medical conditions that are, really making her maybe, have delusions like saying that the family had moved into her house. But this is an example of somebody who really obviously needs some intervention. But again, just be wary of those neighbor calls, because often the neighbors are the ones that are, letting you know in the absence of anybody else that something is wrong. Next, we'll talk a bit about financial exploitation. And unfortunately, it's one of the most common forms of elder abuse, period, but especially in people with dementia who live alone. And unfortunately, the majority of the perpetrators are friends or family members that have a relationship of trust with the person. So here's an APS quote: "Community education and public awareness campaigns don't adequately address the issue of preventing financial loss through theft and fraud, and yet those are some of the most prevalent cases that are being seen." Just in this last legislative session, Georgia got a special prosecutor approved to investigate abuse cases, and we're really hoping that the financial exploitation cases will be one of the areas that they do some additional good work, because again, we see so much of this financial exploitation, and very often it's not recognized until the person has really lost everything. Here's a case study. A man called to report that he had discovered that his father, who's a widower, had been giving away most of his life savings. He was convinced that he needed to do this to inherit a large amount of money from a long-lost relative. And this sounds like a lot like the Nigerian scam. The son had been told by authorities that because his father had not been deemed incompetent, that there was nothing that could be done to stop this. And so this is a problem because, you know, we want to be as respectful as possible to people and let them make decisions for themselves as long as they can. And there are sometimes legal limits in terms of when we can step in if the person hasn't been deemed incompetent. We'll talk about it a little bit later, but that's an area that we really need to do some more work in. Now we're going to talk a bit about social ties and support from others. This idea of social support actually both being able to prevent the onset of symptoms and also prevent the symptoms from declining has just been recently borne out by by research. In the International Alzheimer's Conference was held last month in London, and this was one of the big stories that came out of it. There are 9 lifestyle issues, lifestyle changes that you can make that will actually greatly reduce your risk of getting some kind of dementia. And again, it's something that will, if you do have dementia, that it will slow down the progression. Social support is something that people underestimate the importance of. We need to really look for each person that we're dealing with, you know, what kinds of support they need. Do they need, you know, folks to do fun things with? Do they need support to provide them transportation? Do we need somebody to come into the house just for companionship? Those kind of things. And we need to actively look for opportunities for social interaction. And obviously, really think out of the box and look at non-traditional support systems. Like look at, again, like neighbors, also church groups. Many churches have things like Stephen Ministry where they assign people to, you know, sort of help out with individual cases. So we need to look at who else can we tap into to help provide the social support to our folks. Here's a nurse practitioner. Often the needs of my patients with dementia who live alone are less about their medical condition and more about being connected to others as a way to avoid further decline in physical and cognitive health. You know, the issue of connection to others is so important, and if the person can't physically get out, you know, maybe we can hook them up with a peer support program telephonically, or maybe we can find people to come into the house. But often it's, you know, the isolation is one of the biggest issues, even more so than the medical conditions that are going on. And again, here's a person with dementia. There's no one here to monitor changes with me. Sometimes it's hard for the person themselves to recognize you know, when their impairments are worsening. This slide, I just wanted to talk a little bit more about the social support concept. These are some suggestions from a geriatric psychiatrist who specializes in dementia. It's Dr. Larry Toon, who practices at Emory. I saw him give a presentation recently where he said, 20 years from now, loneliness and despair and purposelessness will be a clinical diagnosis identified as a risk factor for dementia. He really believes that it's such a factor that as we progress in our understanding of this issue, that there'll actually be a diagnosis for it. And then He believes that addressing this issue should be included into the CDC's Healthy Brain Initiative. They talk a lot about other things like exercise, having a good diet, keeping your brain active, those sort of things, but he really believes that we need to address this issue along with the other things as just as important. At every stage of life, meaning and purpose is so important, and in this population, people who live alone don't have a lot of opportunities for purposeful, life and meaning. And so, usually we have to mindfully seek out opportunities for that. And again, sometimes thinking out of the box is good. Like even a Chihuahua. This quote refers to a patient of Dr. Toon's who was very depressed and living alone and having serious issues, and somebody found a rescued little Chihuahua to be a companion to the woman, and her whole outlook changed. She was much brighter, and her symptoms of dementia even improved somewhat. So even something as simple as that usually will make a huge change. And then he recommends finding the hearing aids and glasses and use them. This idea of sensory deprivation, of people not being able to hear other people particularly, is a huge barrier to social interaction. So it's really important that we use those things and get the very as able to enjoy social interaction as they can. And then the last bullet is, we say that very often, with a person with dementia, the world kind of closes in and shrinks. And so we don't want to facilitate that. We want to open it back up for people. So I think these are all great tips for us. So moving on to the recognition of whether dementia is present and getting it diagnosed. In a normal diagnostic process, in the course of an evaluation, people who have observed the person are usually an integral part of that process. Getting input from friends and family members who have seen the person. And with people who live alone, that's not often the case. And so physicians are lacking that piece of the puzzle. And very often, what we see is a person with dementia who does go to the doctor will say, when asked how they're doing, they'll say, "Oh, I'm doing just fine. Everything is fine." And the doctor really has no way of knowing that that might not be the case. So they might just assume that everything's okay and that they're able to manage their medical conditions when they're really not. In this slide, I just want us to look at the concept of how varied the symptoms can be from person to person. Somebody can be very impaired in one area but not in others. So this person, in this example, 1 is very impairment, and 10 means they do that thing great. There's no impairment. So this person, their driving is pretty good still. They're still, they have some issues, but they're still driving and getting by. But in their finances, they just can't do that at all. It's beyond them, and they need somebody to do it for them. But at the same time, they're still really taking care of all their ADLs. They're able to communicate beautifully, and they're still doing most of their household tasks appropriately. So someone who doesn't understand this concept might look at the fact that the person is completely unable to do their finances and assume that they're just as impaired in other areas. And so we really need to keep that in mind. Particularly, let's just say we go into a home and, things look pretty good, things look pretty neat, and the person is able to communicate really well. That's the person who will fool you into thinking that everything really is okay. And, sometimes folks aren't really aware of how impaired they are in other areas. They really aren't trying to give you a false report. They really just don't know how impaired they might be in other areas. And sometimes there's a lot of denial involved. We'll talk about that more in a minute. But, we just need to be aware that just because a person either presents very well doesn't mean that they're not impaired in some areas, and because they're very impaired in some areas doesn't mean that they're not quite intact in others. So we just need to keep that in mind, that everybody is going to look a little bit different. Okay, this is from a geriatrician. People with dementia who are living alone are at greater risk of missing appointments or not seeing a doctor for long periods of time because there isn't anyone to monitor them. Unfortunately, the situation may not be recognized early on by the physician as an indicator that the person needs help. And I just wanted to use this as an example of how, again, how important early detection is. You know, so often people don't get diagnosed until they're in middle stage. But if you can get somebody an evaluation when the symptoms are still mild and it's still early, that means that they have the opportunity to plan ahead, be involved in the planning, do their advanced directives, talk about what kind of alternate living situation they would want. Also, the medications that are available for the symptoms of dementia work better when you start taking them early. They really, aren't that effective when you start taking them later. So there are a lot of reasons to get somebody evaluated as early as possible. And with these folks who live alone, often it just doesn't happen. So let's talk a little bit about our barriers to getting these folks to use services. I'm sure that you all have seen this. Very often folks are just reluctant to accept the help. They're living alone. They have a history of being independent and being able to take care of themselves, and they're just reluctant to seek help or to accept help. That's obviously really common. Also, sometimes people don't. They think if they accept the help that someone might realize how impaired they are, and they definitely don't want to go down that path. They're just afraid to face, what might be ahead. Then another barrier is not being aware that there's a dementia means that they're not connected to service systems. Very often when we do get people help, we don't have a lot of coordination or communication among the different professionals or agencies that are taking care of people, including with the doctor. And of course, the issue of transportation is huge. We know what a huge barrier that is. Poor access to services due to geographic location. It's often a lot harder for people who live in rural areas. Low income is a barrier to service use. And the lack really of programs in the state of Georgia that can help keep the person at home. And then, as we alluded to earlier, there are also barriers in terms of capacity issues. The legal framework to support people with dementia who can't make decisions for themselves is just not sufficient in most states. The law, again, presumes that a person has capacity unless they've been adjudicated as incapacitated. And that really sometimes, again, ties our hands when we know somebody lacks capacity but there's no official adjudication. Sometimes these folks need interventions that they are not happy about, they're not accepting of. But again, we have to realize with these folks, capacity, competency, it's not all or nothing. A person, again, can be really impaired in some areas and still be deemed to have the legal capacity to participate in legal decisions. Or they could have temporary incapacitation due to, some kind of illness. But this idea of, somebody who has poor judgment in one area, to think that they're automatically not capable of signing a living will or a power of attorney, that's just not necessarily true. And the elder law attorneys that I talk to use the standard of, are they really able to understand the nature of what they're signing and what it does and what it means? And if they're capable of understanding that, then they allow them to sign legal documents. Um, we see that this idea that people have the right to make their own decisions no matter what, um, including the right to make unwise decisions. They call that the right to folly. Sometimes we take that too far. Lisa Nirenberg is an expert in elder abuse prevention, and she believes that the right to folly principle has been carried too far in some cases, and it gives some predators a free pass to walk away with homes and estates. And so, again, the idea is that a lot of people say, well, it's their money, it's their decision, even if it's a bad decision. But we really have to look at, is this person, really, is their dementia serious enough to where it impacts their judgment sufficiently to, make it not possible for them to make a good informed decision? Is this a decision that they would have made before they were impaired, is what we want to think about. Here's another quote. The person with dementia living alone can be resistant to leaving what's familiar. So sometimes I'm not able to convince the person to attend an outside program like an adult day center. And, again, this is a very common issue. Sometimes what we suggest for these folks is, particularly if it's a person who's ever been civic-minded or if they've been a volunteer for anything, we say, the folks at the day center could really use some help and some volunteers. And then we might get the people at the adult day center kind of on board with that concept. So when the person comes in, they do let them help and assist them. That happens a lot, and it's one way to kind of work around this resistance. And sometimes, again, we really have to think out of the box to think about how can we counter this resistance and make what we're suggesting to people sound more appetizing. And again, our goal is keeping the person at home as long as possible, as long as it's safe. And so here are the things that, we need to look at. Obviously, we're going to look at, can we get somebody to help with the housekeeping if that's an issue, with the meal prep if that's an issue, and again, making sure that, if that's done, are they safe to, to actually, eat and store the food properly. We're thinking about assistance with transportation and then the medication administration. There are some systems now with pharmacies that, you can have something that actually, pops out the pill, delivers it into a little drawer when it's time. Again, not always 100% that the person will take it, but, we need to think about these ways of increasing the likelihood that they're going to be able to be independent longer. And again, we need to think about, in addition to these, the standard community resources, how can we build up a support system of informal helpers and caregivers like neighbors, church friends, RSVPs, retired senior volunteer program, those kind of things to help the person. We also mentioned decluttering. People with dementia are very, very susceptible to getting confused and overwhelmed with clutter and with having too many things around them. So if we can take out what they don't need, organize the kitchen cabinets and organize the closets, and also label things, that often lowers the anxiety level for one thing, and it also has the result of making the person generally more functional. Another just tip for people being able to live at home longer, if there's a very trusted neighbor, leave a set of house keys so that they can not just let them in if they get locked out, but also come in and help if there's some kind of emergency or some kind of need. When possible, use electrical appliances that shut off on their own. And also, there are some things like if the person just really shouldn't be using the stove, there are knobs that you can put on the permanent knobs that make it impossible to turn it on, things like that. That's sort of a last resort method. And then we obviously need to make sure that the smoke detectors are in good use. Then just in terms of day-to-day life, one thing that can make a huge difference that seems really simple is to try just memory aids. Putting a calendar, say, on the fridge or on a place that they look at a lot, and writing down day to day all of their like a schedule for the day. That just that simple thing helps a lot of people be more functional. Then we need to just think about other things like writing phone numbers by the phone in large print. Put the emergency contacts down, and if people have a cell phone, put ICE numbers in the phone in case of emergency. It's one of the things that the police and first responders will look at, if there's any kind of emergency for a contact in the phone. There's ICE numbers, and they're labeled ICE. Then, if it's possible to form a relationship with the bank that the person uses, and just make sure that they're aware of the situation, they can be a big help in kind of recognizing if there are some serious problems financially, or if the person is giving away huge sums of money, and that kind of thing. People who work in banks are mandated reporters. We need to do more training around that. But particularly, if there is a bank that you can, the community banks probably are the best ones for this. But even with a big bank at your local branch, if you just try to let the folks have an idea of what's happening with the person's permission, and have them be a second set of eyes, that has saved a lot of people from losing a lot of money. Using GPS on the phone, if the person is still able to do that, that is huge. You just tell your phone, go home. If the person can do that, that is a huge help to keeping people independent. We also need to try to coach people to be more comfortable with asking for help and accepting it when it's offered. We need to try to give people opportunities for that and to normalize that for them. I often tell people, when you ask someone for help and you ask them to do a specific thing for you, you're often giving that person a gift, because many people want to help and they don't know what to do. But if you explain to them specifically what they can do, they're usually really happy to help you. Then we need to look at just teaching the people about coping techniques. People with early dementia often get really frustrated that it takes them way longer than it used to do tasks. And so if we can coach them to just sit down, take 10 deep breaths, take a break, just coping techniques, simple coping techniques like that. I actually have had some early stage people who have told me that it has made a big difference for them, that they just don't get as frustrated as they did. There are more ideas for trying to allow people to live at home longer safely at this website. It's dementiatoday.com /living alone. Okay, so we also just need to look at if there is availability for assistive technology. And of course, we're matching it to the person's needs and abilities and preferences. Most of you probably have heard of Simple C. That's an assistive technology, but there are all kinds of different things now. I went to a conference recently where there was a table where there were just dozens of different little devices and things that can be put in place to help people. And there are things also like, monitoring of the person's, for example, their water usage. And remotely, if somebody can see that the person hasn't used their water in, a week, or has used just a minimal amount of water in a week, that can be something to let somebody else know that there's a problem in the house. Lots of technology out there. But sometimes we do have barriers to using the technologies. The person's specific condition might be the barrier. the design of the device. They might not be able to use them. They might not just be able to figure out how to use them. They might not be able to understand the directions. Here's some quotes. I took an indirect way home from the next town over, and I got turned around. Now I keep a GPS in my car. Again, if they understand how to use it, it's a very helpful tool. Then the geriatrician says, monitors for the temperature of the house or the fridge will alert a person to go check and call. I had a female patient with dementia living alone who somehow had the heat turned off in her apartment during the winter, and a neighbor discovered her shivering, and she was hypothermic. We also have situations where when people have wandered and gotten lost, they get confused, and they'll, for example, go into an abandoned house and go up into the attic because they're trying to hide. And it's in the summer, it's very hot up there, so the temperature issues are can be very unsafe. I wanted to give you just some examples of some model programs across the country in case you wanted to jot these down to look and see what they're doing in other states to just kind of help people stay alone longer safely. And for example, in Metro Atlanta, JF&CS, Jewish Family and Career Services, has a program where they'll check on folks who live alone. JFCS is a great organization, and it's secular. They serve people of all faiths. But it's worth just looking at some of the models to give you ideas about how we can serve this population. Again, just for practice considerations, I think we have to improve detection of dementia in older people who live alone, and one way to do this is Medicare's annual wellness visit. It's been in effect for a while now, but a lot of people aren't aware of it. Medicare covers once a year a doctor to do a thorough wellness check on a person, and part of this is a cognitive assessment. There's a place on our website, which is alz.org, that it's for professionals, and they've got the opportunity to look at different memory screenings and all kinds of information about the wellness visit. But I think that we can better use this opportunity to get people evaluated. Even in somebody who is reluctant to go to the doctor, if you say, look, you got Medicare, there's this fabulous benefit that you need to take advantage of, just go and get checked out by the doctor and include the cognitive assessment in that. I think that's an underutilized tool. And then just in general for practice, we really need to personalize our services because, again, everybody is so unique. Everybody has different needs and preferences. And so a one-size-fits-all approach to serving people who live alone is not going to work. We have to really look at, where their abilities are, because most of them still have lots of ability, and where the impairments are, and where we can step in to meet those needs. All of us as professionals who work with this population, I think we need to be more aware of the warning signs. And again, lots of these folks will really fool you with their social skills and their communication skills. There are so many folks who, we think are fine who are really not, and so we just need to be aware that, we need to take a deeper dive and a deeper look sometimes at, some of the folks who are able to communicate but might have some other little clues that things are not right, like the losing weight or the issues with finances and those things. We need to really, again, look at how suitable is this for the person to live alone. We need more tools for identifying people who are at risk. I don't think that we have enough tools in our tool bags to really adequately recognize people. Part of the problem is that we don't have a lot of time to spend with people, and it does sometimes take a deeper dive Sometimes we don't have access to friends and family members, and so we really do need to think about how can we better, how can we increase our toolkits and how can we better identify people who are at risk. The driving issue, again, if we could have a better standardized measure for assessing driving ability, that would be great. There are driving assessment centers scattered around Georgia for people with dementia. Usually they cost, the cost varies, but I think the average is around $350. They're usually done by an occupational therapist, and it's a great tool for assessing a person's ability to drive safely. But, sometimes it's difficult to get the people to participate in it, or they don't have the funds. And so it would be nice to have, a more standardized and more accessible measure for assessing people's ability to drive. And then we need to do better at getting atypical gatekeepers to help identify those at risk. For example, we're trying to train folks at banks on warning signs. We're trying to train policemen and first responders, and so that we can widen our net and find more people who have the skill to identify folks at risk. In terms of personalizing services, I really believe that care managers are such valuable resources, both in terms of community resources and if there's an ability to afford a private geriatric care manager or care manager, that's an excellent resource because they can do a good comprehensive assessment. They can look at the person's individual needs. They can reassess them periodically. And really, I think if a relationship is built, they can get the person really to help describe, what their needs are, what their challenges are, where they're lacking. And we need to not be afraid of talking to the folks about, first of all, do you have advance directives? And number two, what do you want your future to look like? If you were to get very ill, what are your preferences for end-of-life care? We don't have those kinds of conversations enough with people. And again, we should really try to establish interdisciplinary teams to coordinate care with these folks. Most of you know about these particular resources. Of course, statewide, we've got the AgeWise connection with the numbers are there in the slide. They do information referral. They have trained counselors available talking about, options like SOURCE, Medicaid waiver programs, HCBS, CCSP. And they have counselors who use a huge database that can pull up resources in the person's particular area for, housing, adult daycare, home-delivered meals, all of these kinds of things. So the AgeWise connection obviously is a go-to resource. Then just in terms of physicians, when we're getting people hooked up with physicians, ideally the person should be a specialist in diagnosing dementias. Often that's not available, but if we have the option, that's ideal. And we often run into folks who really don't have any options for physicians because they don't have any insurance. Folks who have younger onset dementia and don't have their Medicare, they can sometimes be seen, by hospitals that accept patients in an immediate area. Like at Grady Hospital in Atlanta, there's a program where residents of a couple of nearby counties or, the close counties can be seen there. But also we found one other option is that if there are any doctors in an area who do clinical trials on dementias, if the person is eligible to be enrolled in one of those clinical trials, the doctor will often provide medical care for the person, concurrently along with the clinical trial. And we've had several people get access to services that way who otherwise, wouldn't have had the option. Also, in some places there are like the Good Samaritan clinics and clinics who will do sliding scale services. Then for people who have early stage dementia, these are some really great options for them to get connected with other people and get help for their specific situation. Early stage support groups are wonderful, and we offer them in most regions of the state. We do counseling at the Alzheimer's Association for these folks, and we have a grant to give people this book, Living Your Best with Early Stage Alzheimer's. It's written just for the person with the diagnosis, and it's fabulous. We have peer support programs where people with early dementia will call people who live alone and check up on them. And then we also have lots of social programs. So if you call in and see what's available in your area, sometimes these programs they increase people's socialization. People they feel more connected, more happy, more purposeful. So they're really great groups. Just to let you know, there is an instrument now to evaluate financial capacity, and it was developed by Daniel Marson from UAB, and it's a terrific tool. If you would like more information on that, I'm going to give you the number in a second that you can call. It's the Alzheimer's Association number. Medic Alert Safe Return is the jewelry identification program. Just in case somebody wanders, it's a nationwide database where the bracelet has a number that someone can call to get all the information about where they need to be. Then we have information about GPS systems. GPS systems are getting more and more popular now. And online, in terms of technology and devices that you can use in the home, a great resource is the Alzheimer store. It's an online store. Just browsing through all the options that they have can give you some terrific ideas. Then, of course, the ADRC, the website is there. And that's our Georgia chapter website of the Alzheimer's Association, alz.org/Georgia, spelled out. And this, I want you to really write down this number. This is our 24/7 800 number at the Alzheimer's Association. We want every person with a diagnosis and every person who's a caregiver or care partner of someone with a diagnosis, in addition to professionals taking care of this population, to always have this number on hand, because you can reach us 24/7. You'll always be able to talk to a live person and then get connected to local resources. So spread the word about that number. And the last slide I have is just some references that I used for this presentation. And again, if you have any questions, here's the number to call. Okay, thanks everybody. I hope that was useful. Hope you got some good information.
Well, thank you so much, Suzette. It was such a pleasure. Remember to the viewers that the link to the post test is pasted on this last slide. Please take it at your earliest convenience. A certificate can be provided by entering your email address at the end of the post test. Please remember to view the other webinars in the Dementia Capable webinar series provided by the Rosalind Carter Institute for Caregiving in partnership with the Georgia Division on Aging Services. Thank you, and we hope that you'll join us again.